Hi, I'm Dr. Sheryl Chow. I'm an associate professor at Western University of Health Sciences in Pomona, California, clinical pharmacist and researcher. Today I'm here to talk about heart failure and heart failure with preserved ejection fraction, or HEF as it's called. And in general, heart failure, there's a high incidence of heart failure. Furthermore, there is a very large or high mortality burden on this country, and roughly half of patients that are diagnosed with heart failure end up dying within 5 years. And so you can only imagine the huge impact on the healthcare system in the US, and also the impact on the economic burden of this country. So it is extremely important for all healthcare professionals to be aware of this complex syndrome. Now, HFpEF is different from HFrEF. HFrEF is heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is called HFpEF. And so these two are different in many ways. In one hand, HFpEF patients tend to be older. They tend to be more hypertensive, and they tend to commonly have atrial fibrillation, and so they often have more comorbidities. It also occurs more frequently in females. Furthermore, HFpEF patients are pretty common, so roughly 40 to 60% of patients are diagnosed with HFpEF out of all of the patients that have heart failure. So how do the two differ? And heart failure with preserved ejection fraction have different pathophysiologies. And so when thinking about it, the two primary problems is really impaired filling, impaired relaxation, and also ventricular stiffness, so a stiff ventricular wall. And these are the two primary differences in the pathophysiology. And when you really think about it, considering that a lot of patients have hypertension, and you think about an increased systemic vascular resistance and an increased afterload, that left ventricle has to work harder in order to pump blood to the rest of the body, and it compensates like any other muscle in the body, and so it becomes thickened and hypertrophied, and therefore you're left with those impairments with an impaired relaxation and also ventricular stiffness. And how do you diagnose patients? Because often they present clinically the same way. Patients will become fluid overloaded, they'll have impaired and elevated filling pressures, and what happens is that these patients will become short of breath, and HFpEF patients may present with an S4 heart sound as well compared to HFrEF patients. But you really distinguish it based upon echo. In HFpEF patients, there are different criteria, but roughly these are patients that may have a range, ejection fraction range between 45 to 65%, for example, and therefore these patients could be distinguished from patients with HFrEF. And furthermore, I know cardiologists also look at E waves and A waves to further differentiate. Biomarkers could also be used in order to detect and to be used in conjunction with the physical exam. And you would expect there to be elevations in natriuretic peptides, because natriuretic peptides are increased in response to wall stress, and therefore you would expect there to be elevations here. Although in HFrEF you would have higher elevations compared to HFpEF. So once you diagnose a patient, why do we even have to really distinguish the difference between the two types of heart failures, HFpEF and HFrEF? And that is because patients respond differently. So when you really think about it, in HFrEF patients, for example, there are an armamentarium of medications that can be used to improve mortality. However, it's not the case in HFpEF. And in HFpEF, there really isn't a single drug that has been shown to definitively improve mortality, and that's an unfortunate situation. So the way it's being treated now is really focus in on the clinical symptoms to improve those, and also to treat the underlying symptoms. So, like I mentioned earlier, patients that have HFpEF commonly have hypertension, and so you would treat accordingly based upon the hypertension guidelines. Patients who have atrial fibrillation should be optimized on those medications and treated accordingly as well, and so you're treating those comorbidities. Patients that have elevated filling pressures and are congested, and they come in with shortness of breath and pulmonary edema and peripheral edema, you have to give them a loop diuretic. Now, one of the major differences between the treatment of loop diuretics between HFpEF patients and HFrEF patients is that in HFpEF, you actually have almost a sensitivity to the diastolic volume, and so medications that may slightly reduce the diastolic volume will have dramatic reductions in blood pressure, and so you have to be careful when you first start the patient on a loop diuretic. You should go low and go slow when you titrate up, where you can be a little bit more aggressive with the HFrEF patient. So the current guidelines really focus on those underlying issues. There has been a new update in 2017 recommending MRAs or aldosterone antagonists such as spironolactone. And that's primarily based upon a study that was published a few years ago called the TOPCAT study and the TOPCAT trial. And in this trial, they evaluated HFpEF patients and the use of spironolactone in this population in order to reduce their triple composite endpoint, which was defined as aborted cardiovascular death, all-cause cardiovascular death, and heart failure hospitalizations. And that combination was their primary endpoint. And what did they find? Well, not surprisingly, they found that there wasn't a difference compared to regular standard of care, compared to spironolactone plus standard of care. And that's when you looked at the data entirely, all the data points. However, there was some thought that there might be some regional differences based upon the study, and there may be some regional benefits. So looking at just North America and South America, they actually found that there was a benefit on the triple composite endpoint, but of course that was evaluated in a retrospective way. They also found that there may have been some benefit with heart failure hospitalizations as well. And so that's why MRAs and spironolactone and aldosterone antagonists were added into the 2017 guideline update for heart failure. And it is a weak recommendation, but it indicates that there might be some benefit in patients who have HFpEF. But of course, we always have to be careful about medications, and especially MRAs. And so we kind of learned our lesson in ROUSE in patients with HFrEF, in which after the ROUSE study showed clear benefit on mortality, many HFrEF patients were initiated on aldosterone antagonists. And what did they find? They actually found that there was a rise in hospitalizations in hyperkalemia. And therefore, we really need to be judicious about following up, even though you give a medication that may be beneficial. Yet at the same time, it could be harmful too if you're not following up and evaluating the potassium and renal function. And so this is where multidisciplinary care can really help, because PAs and pharmacists and nurse practitioners and nurses can really follow up to make sure that patients are receiving these medications in a very safe way. So if you ever ask me which one I would prefer to have, HFrEF or HFpEF, I think I would choose HFrEF, because there are many medications that can reduce mortality, whereas now we don't really have any that have clearly shown a reduction in mortality in the HFpEF population. And so part of that is probably based upon the fact that our inclusion criteria have been broad in our clinical trials, and as we know, the population is very heterogeneous, and so possibly, as we move forward, we might be able to narrow that inclusion criteria and become more focused. So I am an optimist, and I do believe that there is hope for the future for HFpEF, and I do believe that it's a matter of time. before they find and identify a medication that will improve mortality.